Welcome, everyone. Thank you for joining us today. We're going to get started in a few minutes as we let folks join the live stream. Hi, everyone. Thanks for joining us today. We're going to wait a few more minutes as we let folks join our live stream. We're so glad you're here with us today. And I see that we have C. Durfee from Seattle, Washington joining us. Thanks for being here. It's morning where you are. It's afternoon for me. So lovely to see. Oh, we see Kirsten Spencer joining from Cincinnati, Ohio, an Eastern Standard Time zoner joining us. Thank you. Please, as you join, let us know where you're joining from in the comments. And we'll get started in just a couple of minutes. And we have Molly also in Seattle. Again, great to have everyone joining us today. I see more folks joining the live stream, so we're just going to give it a couple more minutes as folks join us from the waiting room. And they're pouring in now. We have Stacy from Houston, Brianna from Utah. We have Rosanna joining from Saudi Arabia. Amazing. Jolene from Colorado. Ashley from Nebraska. Great to see all of you today. Well, we know we got started a few minutes late with our live stream today, so we're going to go ahead and kick things off. Hi, Courtney from Illinois. It's so great to see everyone. I wanted to start off by sharing a few reminders about why we're here together today. It is Cesarean Awareness Month, which is the theme of our Accreta Expert series today. So if you haven't already, you can visit our toolkit to get your Facebook cover photo badge to spread awareness this Cesarean Awareness Month. Hi, EJ from Maryland. If you're interested in previous installments of the Accreta Expert series, we have all of our past recordings available on our website, and there's some great topics we've already covered with some fantastic folks in the Accreta community. Encourage you to check those out. And there's a lot of other ways to get involved with the National Accreta Foundation, so please consider choosing us as your charity with Amazon Smile, donating blood or planning a blood drive, joining our letter writing campaign, or taking any of the many actions that are available in our Cesarean Awareness Month campaign toolkit. So it's my great honor to welcome you all today to this Accreta Expert series. My name is Jory Novotny. I'm an Accreta survivor from Columbus, Ohio. And as a board member for the National Accreta Foundation, I'm proud to be here with all of you today for this interactive live stream event, which is part of our recurring Accreta Expert series. This month, our live stream is part of our larger Cesarean Awareness Month campaign. And Cesarean Awareness Month, or CAM, focuses on all topics surrounding cesareans, including reducing preventable C-sections, the patient experience of cesarean delivery, and advocating for vaginal birth after cesarean or VBAC. Nearly 1 in 3 babies in the U.S. are delivered by cesarean, and each cesarean increases the mother's risk of developing Placenta Accreta Spectrum, which is why today we will be talking about some of the reasons for high C-section rates, the downstream impacts that cesarean overuse has on conditions like Akrita, and how survivors, maternal health advocates, and medical professionals can all be part of correcting this trend to improve health outcomes for moms and babies. And I just want to make note that we know this topic can be sensitive, so please know that we deeply respect your birth experiences. We ask that everyone be respectful when commenting and interacting today so that every mom, patient, and advocate can feel safe and welcome. Like many of you who first learned about Akrita when you were diagnosed or after you gave birth, the first time I heard the word Akrita was hours after I'd given birth and wound up in the ICU. And eventually I found helpful information in a community through the National Accreta Foundation. So it means a lot to me, as always, to be a small part of bringing expert information to patients, survivors, families, and providers. Please share your questions, comments, and reactions throughout this event. This is your space. So with that, I am pleased to turn it over to the National Accreta Foundation's Board President, Kristen Terlizzi.
I'm a Placenta Accreta survivor based here in Northern California, and I'm also a co-founder of National Accreta Foundation. Thank you so much for joining us today for this important event. So while a cesarean can absolutely be a life-saving intervention, the fact is that we do too many. And this has caused downstream effects that have contributed significantly to maternal harm. So a large part of Cesarean Awareness Month here in April is bringing attention to appropriate use of cesareans and understanding how we got here, which is what we are here to discuss today. So before we get started, I want to give a big shout out to everyone who's participating in Cesarean Awareness Month, sharing posts, wearing their gear, raising funds, and getting the word out. And check out our CAN page. Jory's going to put a link up there where we have a toolkit of resources that you can use to get the word out. And we have so many ways where NAF has made it easy for you to get involved. So I am thrilled to introduce today's main event in honor of Cesarean Awareness Month. And first, I want to tell you a little more about this series. The Akrita Expert Series is a National Accreta Foundation produced interview series that showcases the researchers, the care providers, and the public health experts who are leading the way in advances related to the pregnancy complication Placenta Accreta Spectrum. And today we are here to talk about the most common surgery in the United States, a C-section or a cesarean section. And it's actually a history of prior cesarean that is the biggest risk factor for developing placenta accreta. Many people don't know this, even those who are at risk of developing the complication, and myself included. I had never heard of placenta accreta until I was diagnosed with the condition, even though I had clear risk factors, including a history of prior cesarean. So decreasing unnecessary cesareans is important work towards preventing accreta because it decreases the amount of women who are at risk of developing it. So today we have with us the incredible Dr. Neel Shah. Dr. Neel Shah is the Chief Medical Officer of Maven Clinic, which is the largest virtual clinic for women's and family health. And he is also an assistant professor of obstetrics, gynecology, and reproductive biology at Harvard Medical School. Dr. Shah has authored many studies and medical texts. He is regularly quoted in major publications like the Wall Street Journal, New York Times, and NPR about the issues affecting United States maternal health. Dr. Shah has devoted much of his research around an issue near and dear to our hearts, appropriate use of C-sections. So Dr. Shah, thank you so much for your dedication to this field. It means so much to us. You are a true advocate for maternal health, and it is such an honor to have you here with us today.
Thank you so much. I'm really honored to be here, Kristen. And Joy, it's great to meet you today. And thank you to the leadership of NAF. I remember, so the ACOG meeting, the next ACOG meeting is in about a week and a half, and it's in San Diego again. And the last time it was in San Diego, it was 5 years ago. And I think it was the first time I met Kristen. And I think that the foundation was still kind of like a twinkle in your eye. It was like just the seeds of this idea were being formed. And it's incredible that on a Friday afternoon, East Coast time, we've got people from like Saudi to Nebraska. It's just a real testament to your leadership and the impact of the advocacy over 5 years is not that much time. And I feel like we've really built a movement here. So I was lucky enough as an academic early in my career to study an issue where, here's the thing, like in science, at least like classically, the way that you're trained at Harvard is like, that there's a bright line between science and advocacy, that like when you're doing science, just be like neutral and objective. Of course you have a hypothesis, but you don't have like a strong point of view. You're like, and then advocacy obviously is necessarily different because you have to like wear your point of view on your sleeve. And the thing is, like, what science gets you is it tells you that what you think you're seeing is true. It gives you confidence that you think what you're seeing is true, but it doesn't actually create change. So you need both working in lockstep. And getting to meet you and Jill Arnold early in my career, now Jill and I work together again, like formally, but like that was really transformative for me, because at the end of the day, no matter what you're doing, you want to make an impact on the world, and you need both. So I brought a couple things to share. They're in a slide deck, and I thought I could tell you a little bit about like my journey into thinking about C-sections. Like, I am an OB. I also, like, when I went to medical school, I was like a dude in my 20s. Like, obstetrics was like the last thing I ever thought I was going to do. I did it first in medical school to get it over with, because it was like, I don't know, like nothing against it, but I just didn't think that's what I was going to do. And then you get to deliver a baby, and you're, like, you have to kind of have no soul to not think that's cool. So I was really drawn actually to the surgical aspects of the field. So at the end of the day, I'm a surgeon. I like doing C-sections. But then, I finished my residency and I became a public health professor, and I couldn't square the fact that, like, when I do a C-section, I thought I was a pretty good doctor. I was like, when I do a C-section, I'm always right, because if the baby comes out and it looks like perfect, well, it's a good thing to do a C-section. And if the baby comes out and looks kind of lackluster and has low APGAR scores, I'm like, well, that was a sick baby. It's a good thing I did a C-section. So either way, it was pretty good to be me. I was always right. And then I like stumbled onto this thing where, like, we do a lot of these C-sections. We can't all be right. And trying to reconcile how I was always right, but we can't all be right, started me on a journey probably like almost a decade ago. I'm old now. Anyway, it's been quite a journey since, but I want to just walk you through what I've learned, what I think is going on, why I think most of the framing around this problem is not right. And I've been trying to tear down the conventional wisdom around it all this time. I'm not quite there yet, I've not succeeded, but what I think the right frame of the problem is, what I've tried to do about it, and maybe I'll even like tell you how an app can help C-sections. Actually, it can't. I'm at a virtual clinic now, Maven Clinic, as a CMO, and an app cannot fix healthcare. But the devices that people carry in their pockets and apparently spend 7 to 8 hours of their time looking at can definitely be a portal into a human service. And if we improve access to the right kinds of care and use technology in that way, I do think it can make a difference. And I'm going to try and maybe show that to you too. So should we throw the slides up? Is that the right?
So many fantastic topics here. I can't wait to get into the slides. I did want to give a little bit of an introduction into Akrita first as well, just because we have many folks joining us today who may have varying degrees of familiarity with the condition. So would you mind actually giving us a brief description of Placenta Accreta?
Sure. I'm nervous describing Placenta Accreta to you. You would know better than me, but this is my understanding of it. It's an obstetrician's worst nightmare, although probably not as bad as somebody who's actually been affected by it. This is how I would describe it. Most surgeons don't operate in a place that they've operated before. If you're like a vascular surgeon or a neurosurgeon, you have to go back and operate in a place that you were before. That's a bad day in your work week. And the reason is that when you do surgery, you create scar tissue. And if you have to go back, you've got to like work through all that scar tissue. And obstetricians are probably the only surgeons that routinely cut on the same scar over and over again. So what is a bad day for a neurosurgeon is like a Tuesday for an OB. And like the first time you do a C-section, it's a very straightforward surgery. You can train a brand new doctor how to do it in a couple of weeks. It's so straightforward, in fact, that when you really need to, you can go from skin to baby in 30 seconds. And sometimes you need to. But the second time you do a C-section, you have to like go through all that scar tissue. And it's a more complicated surgery. And the third time, it can be even more complicated. I have done C-sections where it's like, not to be graphic, but I think it's important. It's like operating on a melted box of crayons. Probably like younger people don't really remember this, but I feel like that was a common occurrence in the 80s. Just like you'd leave a box of crayons somewhere, they would just melt and all wax together. But like the thing is, the placenta is an organ that only exists in pregnancy and is very poorly understood. because it only exists in pregnancy and it's often discarded. But it's actually the most fascinating organ probably ever. If I could pick a cell that I could be, it would probably be a syncytial trophoblast, which is the cell that like mediates what gets in and what doesn't. Anyway, nerdy aside, but like the placenta is a big bag of blood vessels. It gets 25% of everything that the heart is pumping. And if it gets caught up in the melted box of crayons and all that scar tissue, it doesn't detach properly. And people can bleed a lot.
Exactly.
And sometimes to death. Yeah.
We actually don't know what it is that gives the placenta the message of how deeply to embed into the uterus in a normal pregnancy, but it is something about the existence of scar tissue in the uterus that makes it much more likely for it to attach too deeply, which is what happens with Placenta Accreta Spectrum. And it becomes a very difficult and dangerous situation to go ahead and detach that placenta, being that it's blood vessels and the risk of high life-threatening bleeding is high for the mother. So fantastic introduction. And I'm curious, Dr. Shah, too, do you have any personal experience with Akrita patients or encountering Akrita in the operating room?
Of course. I spent the last decade and a half in tertiary academic medical centers with helipads on the roof. So we took care of people who had known Akritas that were specifically coming to our Akrita center to manage their condition so that we could have all the things, the team of surgeons, the interventional radiology suite, all the things, the blood bank. And I've also been in situations where you find Akrita in the middle of the night unexpectedly.
And those are the cases that keep us up at night as well. So thank you so much for this great introduction. And I'd say let's go ahead and get started with your presentation.
Great. And it doesn't seem like this is going to be a shy group. I think we're going to have a good conversation, but maybe this will just set up, I don't know, some more fodder to talk about. So Kristen mentioned C-sections are the most common surgery in the US. They're actually the most common surgery in the world, the most common major surgery. There's no laparoscopic, minimally invasive C-section. The only way to do a C-section is with a large abdominal incision. And although they are life-saving, as Kristen said, I think the decision to do a C-section is probably the most common and consequential surgical error in the world. So let me just say that again. There's hundreds of millions of operations that happen to people around the world. The most common and consequential surgical error is probably the decision to do a C-section. It's not that C-sections are bad. It's that we either do too little too late or too much too soon. We either don't give people access to C-sections when they need them in a timely way to save a life, or we do them way too much. And it seems like in every part of the world, the minute that you stand up the capability to do a C-section, you swing towards overuse, massively. Let's go to the next slide. So rewind the tapes. It's 2013 or so, and I'm an OB, and honestly, had planned on moving back home to New Jersey and hanging a shingle and being an OB in my community. But Atul Gawande, who is a surgeon and a writer and was at my hospital, was starting a thing that he called Accreta Labs. And it was around this idea that when you're trying to improve things in healthcare, you kind of fix it one at a hospital at a time, but the changes don't scale. And what he had done just a couple years before is develop this thing called the surgical safety checklist, which is before a surgeon picks up a scalpel, in the same way that before a pilot hits the throttle of a plane, you have to run a checklist. And it turns out if you do, you drop mortality in half for every surgery on every continent. After the smallpox vaccine, the WHO thought it was the most impactful thing they ever did, the surgical safety checklist. And it worked in Tanzania and it worked in Seattle. And so the question was, how do we do that again in other areas of healthcare? And what about childbirth? So he got me swept up in this idea, and I joined his lab as a brand new faculty member at Harvard. And the direction I had was, here's a blank piece of paper. What can we do in childbirth? And I had 50 ideas, but he was come back to me with the one thing that's going to make the biggest impact. And the more I dug into it, the more rabbit holes I dropped into. What became clear is that not only was C-section rates the right thing to focus on and the right frame around the opportunity in maternal and child health, but there was just a lot of exceptionalism. Like, so, okay, from the early 1970s until now, the C-section rate in the country has gone up by 500%. Somebody in 2022 is 500% more likely to get a C-section than in 1972. There is no other healthcare service that I'm aware of that has increased in utilization by that much. And if you were to pick 3 statistics to describe maternal health in the US, it is, number 1, an American today, or a person living in the United States, is 50% more likely to die in childbirth than her own mother, 3 to 4 times more likely to die if she's Black. Term infants are 0% better off over that last generation of change. And you're 50% more likely to get a C-section. So it's like, this is a surgery that's like designed to make people better off. I know I'm like being repetitive here, but I just like still can't wrap my mind around it. It's designed to rescue people. We do it 500% more. Term infants are 0% better off on average, and moms are 50% more likely to die. So it's like, what are we doing? What are we doing? And over this time period, there are a lot of people who've been practicing the whole time, like, you know, and so I asked them, like, what's going on? Why are we doing so many? And there's a bunch of conventional wisdom. Moms are older than they used to be in the 1970s. There's more diabetes, more hypertension. There's more IVF, and there's more like multiple gestational pregnancies. All of this is meant to justify why C-section rates have gone up by so much. And then the thing is, that doesn't bear out, because if you're a healthy 18-year-old today, you're like 50% more likely to get a C-section than when you were born. It's like not really explained by demographics. C-section rates go up in like every demographic cut. The stat again, yeah, moms are 50% more likely to die in childbirth today. Actually, that's compared to 1990 when we first started tracking it. So maternal mortality in the United States has been going up for 25 years with a trend line. Actually, 30 plus years with a trend line. And we just got data from 2020, which was the first year of the pandemic, and it's continuing to rise. And notably, a lot of what's driving that is inequity, right? It's the fact that if you're Black, you're 3 to 4 times more likely to die. So anyway, like, what is happening? And then, of course, like the too much too soon thing. You can hurt people both ways. You can hurt people in healthcare when you do too little too late and when you do too much too soon. And we just talked about what Akrita is. Akrita is a condition that is caused by C-sections. There's another cause of placenta accreta. We're causing a condition that's deadly as maternal mortality in the United States is going up. By the way, if you're Black in this country, you're much more likely to get a C-section too. And trying to explain this, one of the things that Atul, my mentor, who's a journalist, actually, he's a writer in addition to being a surgeon, encouraged me to do is go see what it looks like to give birth in America. Like, I'd only really delivered babies in Boston. So he was like, you know, go see. And so I visited critical access hospitals in Oklahoma and birthing centers in New Mexico. And what I saw is that it's not just that C-section rates have gone up over time. It's also that if you were to freeze time and look across geographies, there's a lot of variation in C-section rates by hospital. So C-section rates go from 7% to 70%, depending on which hospital you go to. In some parts of America, like in Miami-Dade County, the hospital that you pick can change your odds of having a C-section like 3-fold. And it's not just that you have that much variation. I know, right? These statistics are all real. Then you're like, okay, well, one hospital might be taking care of higher risk people than the other, and that's why their C-section rate is higher. So you're like, let's only look at the lowest risk people, the people for whom it's their first baby, baby's pointing head down, you know, only one baby in there, all that stuff. And you don't see 10-fold variation anymore. You see 15-fold variation. So That means this is the only healthcare service where after you account for risk, you see more variation, not less. Which is how I came to the conclusion that your biggest risk factor for having a C-section is not your personal preferences, it's not your personal risks, it's like which hospital you go to. And that really informed the approach that I took. I will tell you, and I want to be very clear about this too, there's a lot of people who want to like blame moms for the C-section rate. It's not a thing. Like moms are not demanding C-sections. It's less than 0.5% of people who electively request one. So that's just not it. It's not helpful to have C-sections get reimbursed higher, or to have medical liability practices in place where people feel like they have to act very defensively. But it doesn't explain this either. Even in places where reimbursement has been the same for long periods of time, even in places where medical malpractice policies haven't changed, C-section rates have continued to go up. So almost every conventional explanation for what's going on doesn't bear out in the facts. So let's go to the next slide. One of the things that I observed in just going around the country is that one, that original C-section really matters, right? Like Kristen talked about, like the cumulative impact of risk, but especially for that first C-section, it's not about the decision to do a C-section, actually. It's about how people's labor is managed, and actually even more fundamentally, how well supported people are in labor and even upstream of that in their pregnancy. Small hospitals may have a hard time offering VBAC. That is true. And I know that in recent years, actually going back even before I was spending much time in this space, there's been a lot of efforts to try and change that. But also, to be able to do a VBAC safely, you need 24/7 in-house anesthesia, and a lot of smaller hospitals can't afford it. And it's part of the complexity of our healthcare system is that it is very hard for small hospitals to deliver babies at all, let alone take care of people safely when they need to VBAC. And there's probably more to be said there. But let's go to the next slide, and then we can talk more about that, what we can do about it. Okay, so I spent like a year or so, maybe longer, year and a half, on an Americana tour, like going around seeing how babies are born, and came back with this cartoon, which is to imagine the labor and delivery unit as a pressure tank. And at the end of the pressure tank is a dichotomous choice that we face in the hospital and in life between doing the right thing and doing the easy thing. And in the hospital and in many areas of life, the right thing to do and the easy thing to do don't line up, right? And there's always pressure in the system to do the easier thing. You can either support someone in labor who's had a protracted labor that's taken way longer than average, who has an ambiguous fetal heart tracing, who is hypertensive and so they're high risk, and incidentally has a fever. None of those are indications for doing a C-section by itself, but all those things cumulatively make it easier and easier and easier to just do the C-section. And one of the things that we found is that there are a lot of things that were going unmeasured that influence the amount of pressure in the pressure tank. For example, one of the most surprising was I found 2 hospitals on the West Coast that have the same number of rooms for people to give birth in. And one place did twice as many deliveries per year as the other, but they both thought they were at their capacity limit, meaning both thought they couldn't possibly do any more deliveries. They were full. But one place was doing twice as many as the other. The only way that's possible, according to Isaac Newton, because like 2 people can't occupy the same space at the same time, is that one place was just moving people through a lot faster. And the only way to do that, one of the main ways to do that, is just to do C-sections sooner. We ended up proving this in a bunch of different ways, but one of the ways that was interesting was we realized that every public use facility, including labor and delivery units, have a fire escape map on the wall, and that the fire escape map is a floor plan. And if you look at the floor plan, you can figure out how many labor and delivery rooms there are, because the labor and delivery rooms are always the ones with the windows that are arrayed along the outside of the unit. And if we knew how many babies were delivered at a hospital per year, and somebody sent us their floor plan or their fire escape map, we could predict the C-section rate. We can go to the next slide. Then the question is like, what do you do about that? That feels like a really hard thing to unwind, right? Like, can we fix the floor plate of the hospital? And we actually looked into that as a lever, and you can. Turns out there were no rules for how many rooms you need based on the number of people you take care of. And we I think at least got to a place where now there's some rules, but we also needed like systems, and had two design principles for what to do. One is everything that we do to try and improve systems in healthcare makes it harder to be a doctor or a nurse. Almost everything. We're like, here's another thing that you've got to do on top of a job that's already like kind of at its breaking point, right? Like 1 in 5 people 2 years into this pandemic that works in healthcare on the front lines is leaving. They were burned out before the pandemic. They're even more burned out now. Any solution that you put in place has to also be mindful about how we're making it so that the right thing to do is also the easier thing to do. I will say one of the things that drew me to medicine is the fact that it recruits people who are willing to do the right thing over the easy thing, but it's not a fair expectation of any human being. The other thing is that like childbirth is a team sport, you know, like you shouldn't, there's like a Lifetime show I think about like being born in the wild or something. Like you shouldn't wander off into the woods and like have a baby. Like, you know, we can go on and on about that actually, but like, I think Homo sapiens are designed to help each other out in a bunch of ways, but compared to like, say, other primates, you know, an interesting cocktail party fact is that humans, 90% of the time are born facing away from the mom, whereas like gorillas are born facing the mom. And the reason is that gorillas have a wider pelvis than we do, and they have a flatter skull. So they negotiate the birth canal very differently. We walk upright, which gives us a narrower pelvis. We also, because we walk upright, have our hands, and that gives us dexterity. And we have these big frontal lobes, which is where our social intelligence comes from. So I really think that we're designed to help each other out. And the point of this is like, childbirth is a team sport, and we've got to like think about that in any solution that we design. It's not like the surgical safety checklist where the patient is asleep. Any solution has to center the person who's actually the one giving birth. All right, so the next slide. What we did is we spent a couple of years and good amount of resources trying to design what that kind of solution could be. It had to be anchored to the evidence. It had to bring in a number of points of view, advocates, nurses, OBs, engineers, and it had to be adaptable enough to be able to work in really different settings. So let's go to the next slide. What we came up with in the end was something that had no AI in it, no blockchain. It's like very simple. Turns out like every inpatient room in America has a dry erase whiteboard in it. And it's mostly used by nurses to kind of talk to themselves. It's like small, it's in a corner, they're highly variable in information. So what we did is, this seemed non-threatening. We just took like a big one. We took the same dry erase whiteboard, we made it big so that everyone in the room can see it, especially the mom and her partner or her support person. And we structured it so it had the same information every time. And we simplified the information so that everyone could just get on the same page, especially the mom. So let's go to the next slide. This whiteboard only really has 4 pieces. There's a place where you write down the name of every member of the team, starting with the mom herself. That's not just so you know everyone's name, it's to create psychological safety so that everyone has permission and opportunity to speak and that roles are clear. You know, it is a team sport, childbirth, but also what's interesting is that that team has to come together and become high performing for one of the most important moments of our lives, but they've never been a team before. So we tried to like look into the science of what makes a good team. And it's like role clarity, psychological safety, structured communication. So there's a place where you write down every member of the team, a place where you write down the things that only the mom can tell you, which are like preferences and symptoms, but things that are neither. Like how much energy you have to push at 3 a.m., 2 hours in. That's not a preference. That's not a symptom, but it's like very important. Then there's a place where you write down the plan. And then there's a place where you write down the next time the team is going to get back together again and talk. And that's so moms don't feel like passengers on a plane that's being held on the tarmac without the pilot coming overhead and telling you what's happening, just like what happened to me yesterday. But that's like most moms in America. That's how they feel when they're in labor. And it turns out that's the other key step for creating a high-performing team is aligning people around expectations. Let's go to the next slide. I thought this could help with the C-section, right? I don't know, like, you know, if the actual thing isn't the decision to do it, it's upstream. It's like, you know, trying to get people, the idea here is like, in 2022, you don't know how big a baby is until it's out. There's no technology that tells you. At 3 a.m., when someone's been pushing for 2 hours and then 3 hours and then 4 hours, you have to decide what you believe is going to happen. And if you wait too long, moms and babies can get hurt, right? Which is why we go to the C-section. I have a lot of empathy for that. But when you're making decisions under uncertainty, ideally you're doing it with all the information that should be available to you in the room. And that includes things that only the mom can tell you, things that only the nurse can tell you, because usually the nurse is the one who's doing most of the labor management and at the bedside. And hopefully the OB or the midwife can add some things to the conversation too and come to a good decision. So anyway, we wanted to prove that this could work. We called this process team birth, which is not just the whiteboard, it's the conversation that happens in front of it. And we ran a clinical trial. We registered on clinicaltrials.gov, and we ran it at community hospitals on both coasts and in the heartland. It involved hundreds of clinicians, tens of thousands of families that were thousands of miles apart. It was a really complicated trial. And let's go to the next slide. This is what we found. So almost all of the patients, the moms, felt like they had the role that they wanted in their own care. They felt like they understood what was happening to them, and they felt like their preferences made a difference. That was exciting, but what was even more exciting is we found that the more huddles, we called them, the more conversations that happened in front of the board, the more likely it was that they believed those things with statistical significance. And it also turned out the clinicians didn't hate it. Not everybody was like thrilled about doing this, but over time, people felt like it improved care for their patients. And most encouragingly, 84% of the doctors and nurses felt like it clarified C-section decision-making. I told you how I felt about always being right about doing a C-section, so I thought that was a big deal. The other thing that this taught us was that historically, and this is the whole problem with C-sections, this is the root cause. If you're trying to improve care, it's like first do no harm. And so you're so hyper-focused on safety that you treat people's experience of care as a secondary luxury that you get to after you've made people safe. And what this showed actually is that the way that you make people safe is by attending to their lived and embodied experience, by listening to them, right? Like we got the entire thing backwards. In the whole story of Black maternal mortality, like that's what's happening. People aren't being listened to, they're not being heard. And so that's what we showed in like the paper. And what we also saw is that C-section rates did in fact go down. At our Washington hospital, for those of you who are in the Seattle area, at Evergreen Hospital, which had a C-section rate in the 30s and had been trying for like a decade and a half to decrease it, we got it down to like the low 20s. And then even more encouragingly, sustained it after the trial for years. We also saw in our Oklahoma hospital that in addition to C-section rates going down, unexpected newborn complications and severe maternal morbidity went down too. So we go to the next slide. Or what's on it? Oh, this is on it. So that was what I was up to. And so this brings us up to like 2020-ish. We ran the trial, showed the results. Pandemic happened. In spite of the pandemic, we started to scale this program up across Oklahoma, working with the government, and across Michigan, working with one of the big health plans there. And, it's working. I think it's going to help. I think it's going to make a difference. Like, I think it'll make an impact on C-section rates. Hopefully it'll make an impact on Akrita rates. But it's helping with something more broad, right? Which is like the root cause here is like not empowering people who are giving birth, and also having a very low bar where we're like, people have goals in childbirth other than emerging unscathed from the process. So I think in our sharp focus on maternal mortality, we forget that we shouldn't be aiming for the floor. We should be aiming for the ceiling. The goal is to make sure people are supported and empowered. So during the pandemic, I had a midlife crisis, I guess. And like, I guess, that's maybe a way of trivializing it, but I was thinking like, there are deeper root problems here than labor and delivery is maybe the last mile of the problem, but there's more to it. And what really led me to believe that was the story of Amber Isaac and her partner, Bruce McIntyre, who's in this picture. In April of 2020, when New York City was really the epicenter for the whole global pandemic, Amber gave birth. And actually, going back to March, she wasn't feeling quite right. But in March, the healthcare system really broke. And in ways that are, for the people working on the front line, you have to have a lot of empathy for. But, they were overwhelmed. They were trying to keep pregnant people out of the hospital that didn't need to be there, given we had no idea how people were being infected or what the consequences might be. And Amber was trying to get in touch with somebody and couldn't. She developed HELLP syndrome, which is a severe form of preeclampsia. And by the time they realized her blood couldn't clot and that she needed a C-section to give birth, it was too late. And she died. And her story and Bruce's story really got me thinking about her C-section was avoidable, but not at the point where she got to the hospital. It was avoidable at the point where she had access to trustworthy care and support during her pregnancy. And so along the way, I befriended Bruce, and actually two filmmakers, Paula Eiselt and Tanya Lewis-Lee, were following Bruce. And then through our friendship, ended up following me and some of the team birth work we were doing too, including like some of that work in Oklahoma. And that got turned into a film. And that film premiered at Sundance a couple months ago. It won the Special Jury Prize for Impact. It just got picked up by a big distributor, the Disney Onyx Group, and it's going to be on Hulu in a couple months. It's kind of crazy. But it's really, really powerful documentary. And what makes it powerful is not just how wrenching Bruce's story is actually the power of what can happen when you advocate. And that's why, first of all, I would do anything that Kristen asked me to do, but it's part of why I think it's so important for spaces like this to exist, and why I was so honored to be here, is that there's tremendous power in what you're doing and advocating at the community level. And this film really shows like how Bruce and other families in the Bronx held the healthcare system accountable and are really leading change in ways that I hope will inspire a lot of other people. Let me go to the next slide. I will tell you, so like 8 months ago, I made a pivot in my career. I was an academic doctor. I delivered my last baby in July, at least for now. I gave all my grants away. And I joined Maven Clinic as the chief medical officer. Maven Clinic, as Kristen mentioned, is a virtual clinic. And I was really skeptical of digital health before I really entertained this idea and before I understood that something like this could have saved Amber's life. Because you can't deliver a baby through a screen. And as an OB, I'm very tactile. So I was like, what is this really? And even team birth was a very analog solution. I don't believe today, and I never have believed, that an app can fix healthcare. We've talked about that. but it can be a portal into a human service. What happened to Bruce and what happens to so many people, to Amber, is that where you live and what is physically proximate to you, if you don't have Stanford, in your backyard, it is the difference between life and death in America. And the promise of digital health should be to change that paradigm so that a zip code isn't people's destiny, that what's physically proximate to you isn't a constraint on what you have access to. So let's go to the next slide. So Maven, when I joined, they primarily worked with large employers and offered this benefit where people have access to care and support 24/7 virtually through their phone or through their computer. I joined because I saw an opportunity to deploy the same capability much more broadly than people that are working for large employers. And as of January, we're actually working in Medicaid in places like Arkansas. And what we're trying to do is put our fees at risk to be able to show that if we don't make people healthier, we don't get paid as much. And the way that we show that we're making people healthier, one of the primary ways is that we're decreasing C-section rates. And it's hard maybe to imagine how a virtual service can decrease C-section rates. But part of what I'm excited about are things like this. If you have gestational diabetes, you don't need a surgeon necessarily. You don't even necessarily need an OB as your primary person. You need a nutritionist because changing your diet is really hard. And if you have someone who can look through your phone at your refrigerator and help you plan a meal, it can make all the difference. And that's the difference between good glycemic control and uncontrolled diabetes. And that's the difference between a 34-week delivery and months in the NICU and an induction, and maybe somebody getting to spontaneous labor and having a much higher chance of having a vaginal delivery. Let's go to the next slide. This might be my last one. The other thing that you can do is you can find the people who have had a C-section the first time and think that they're going to have a C-section the next time because, that's what happened last time. And 90% of people who get a C-section the first time end up getting one the second time, whether they need one or not. And all we do is we find the people who think that they're going to get a C-section the second time, and we just talk to them. And it turns out talking to people about that at the right time in the right way from a trusted source with a human being increases the odds that they're going to have a vaginal delivery 7-fold. So that these are part of what gives me a lot of hope and faith that maybe the position that I'm in now, I can help, or we can help make C-section rates more appropriate and maybe prevent Akrita along the way. Go to the next slide, maybe. Yeah, let's keep going. But I'll just say, actually, let's go back one. Just to evangelize digital health a little bit more, 5% of Americans, because this is all tied together, right? There's no way that you can go through something as physically traumatic as an Akrita and not have it impact your mental health. And actually, part of the big opportunity that we have, whether it's addressing Akrita or any of the broader issues in maternal health, is to not treat people as a uterus, right? People are not just a uterus, they're people. 5% of Americans who are pregnant get to see a mental health provider. One of the things I'm really proud of is that 30% of the people on Maven say that we're helping us with depression. We're helping them with depression or anxiety. And that when we set up intentional programs to do it, we increase the amount of people that we're helping by 3-fold. So let's go to the next slide. But that's what access can do. And these are the kinds of things you can do when you uncouple healthcare from geography. And I should end on this just because, as many of you know, it was Black Maternal Health Week a couple weeks ago. And much like the National Akreta Foundation getting to a point in just 5 years where we've got people from across the world coming together on a Friday to talk about this, another signal to me that there's a lot of hope that we're going to make a big impact here is that we went from not a lot of people talking about this to the White House platforming the need to improve maternal health. And so we're just getting started, but yeah, that just gives me a lot of hope. So that's what I came to say, and happy to talk about anything that we want to talk about.
Neel, thank you so much. This is just amazing as always. You are so eloquent with such insight into all of these different factors. It's an amazing having you here today. I want to hit on some of the highlights too. I'm still chuckling over your comment earlier about wanting to be a trophoblast, by the way. Love the gorilla fun facts. And thank you for bringing so many, statistics to this talk as well to help folks understand the larger context here, which is the crisis of United States maternal morbidity and mortality. And you highlighted how a woman now is 50% more likely to die in childbirth than her mother was. And I think it's important to highlight too that the United States is the only developed country where maternal mortality is actually going in the wrong direction. So this public health work and this advocacy work that we are all engaged with is so incredibly important and timely right now. I'd also like to thank you for highlighting the racial, the socioeconomic, and the location factors, which are playing such a huge role in the disparities of outcomes that we are seeing within maternal health. And I did want to touch on too, while a C-section doesn't explain all cases of placenta accreta, a history of prior C-section is the overwhelming majority of accreta cases. So there are other cases of accreta associated with like placenta previa, other uterine surgeries, and there's some really interesting studies coming out recently as well on the link between accreta and IVF, IUDs. And I think the overall consensus there is that there's just still a lot that we don't know that we're learning. But I really encourage all of us who are interested in improving maternal health to be focused on appropriate use of cesareans. Neel, you gave some interesting stats about how the C-section rate has increased 500% since the 1970s. And over that time, we have seen placenta accreta cases quadruple. One of the most powerful data points that we can give is the earliest numbers that I've seen of placenta accreta incidents as far back as the 1950s. It was estimated to be as rare as 1 in 30,000 deliveries. And then fast forward to today and fast forward to our increased C-section rates. And now we're seeing accreta as common as 1 in 272 pregnancies. And that's just crazy. So decreasing unnecessary cesareans is really the low-hanging fruit in accreta advocacy world for how much of an impact that we could make in decreasing the amount of women affected by this condition if we could have more appropriate use of cesareans. So moving on, I love that you referenced your architecture study, by the way. I find that just so fascinating that there are factors that we don't even think of as being directly related to health outcomes, which can have such an important role. So I love that you touched on dignity in childbirth as well, that women have goals other than escaping unscathed in childbirth. And I think that that's such an important focus for maternal health right now. So as you've been getting the word out and advocating for trust, respect, and with your Team Birth initiative, how do you feel that that's been perceived within the birth community?
I mean, it seems like it's been resonant with the birth community because it's where I got it from. And like make it up, but I think what has been more challenging to translate is what that means operationally. So one of the things that I feel like has been top of mind for me is we're living in the strangest of times where there's like no ground truth. And the existential issue for the healthcare system is trustworthiness. And it's not the job of the people that we serve to be more trusting of us. It's like our job as a system to be more trustworthy. But like that's not just a virtue. Right? Like when we talk about dignity, it can sometimes seem that what we're asking for only has a moral dimension. And not only, but like, of course, it's where you start, but trustworthiness is also an output of a system that's either working or not working. And that provides the opportunity to really define what that means and operationalize trustworthiness. You need 3 things. You have to be competent, which we're like, got some work to do there. right? But you have to produce equitable outcomes, which is my definition of competence. It also turns out in 2022, like rampant disinformation and just like, like being competent isn't enough to be trustworthy. You also have to be reliable and consistent. You've got to show up for people and they expect you to. You have to affirm them. You have to. People need to feel seen and heard by you. And that last piece is the hardest piece. But I don't think anybody disagrees with me, like on the moral level. I think where people disagree with me, and honestly can and should, because you're not leading unless you're like bothering people, is what I mean by listening to people.
Something that I've said for a while too, that I'm glad to see resonating here too, is the perception of personal safety is just as important as the actual personal safety. So it is more than creating that safe environment. We really need to be valuing the patient experience and understanding all of the different factors that go into shared decision-making and respecting the lived experience in order to reach these goals of dignity and respect in childbirth as well.
Totally. Yeah. I mean, it's so funny. I feel like, there's opportunities to treat people in more dignified ways across the whole healthcare system, like from like the Johnnies to like everything that we do and subject people to that we've now normalized. But there's something specific about childbirth where, because we're all born, I think, this is my theory, I don't know, this is my hot take, but like there's a profound lack of empathy for people that are giving birth. And there is a lot of like talk, right, about like in pregnancy, we're like very careful with people who are pregnant. And then we like forget about people after they've had the baby. And we also just subject people to things like whatever the status quo is in every part of the world that I've been to when it comes to childbirth is treated as normal, no matter what the status quo is. So in like Malawi, it's a really high maternal mortality rate, much higher than the United States. There's a lot of fatalism. It's like normal. It's just like what happens. On the Upper East Side of Manhattan, in Soho, where I was like earlier this week, C-section rate is 1 in 3 people get a C-section and 1 in 10 of their babies goes to the NICU. And like, that's just normal. It's like, look to your left, look to your right, someone's had a C-section. And like, of course, it's crazy if you take a step back, but there's like that opportunity too, is to redefine what normal is.
Absolutely. And I think that's where it's important too, giving this context within the bigger picture and showing that disparity of C-section rates between neighboring hospitals. I mean, those types of data are just so illuminating and really help display that there's something going on here and we can do better. So one thing that I'd love to get your thoughts on are the fact that placenta accreta has become as common as it is, 1 in 272 pregnancies, and just the staggering amount of resources and talent within our medical system that's currently being devoted to better understanding and treating accreta. I am the first one to say I love the Placenta Accreta Spectrum community, don't get me wrong, but some of us say that we shouldn't even exist. And the economist in me has to recognize that, the proliferation of what has become the field of accreta is really direct evidence of cesarean overuse and the trade-offs that we are making in a society as a result of these high C-section rates. So what do you think about that?
I think a good place to start is the value of the National Academy or the National Accreta Foundation is the opportunity to advocate for change, but also the really important community among people who've had their whole lives shaped around this deadly, terrifying condition that's meant to coincide with like one of the happiest times in your life, as people say it. But it's like, building your family is like existential for most people. And like the idea of coupling that with a deadly condition that is not well understood, all that stuff. I think probably one of the most important things that you're doing is bringing people together who've survived this condition. And that has tremendous value in itself. But I mean, in so many ways, it's the tip of the spear, the condition. So I don't know if I totally understand the question. It might be that maybe it's just not common enough or something to like deserve the attention of breast cancer or something like that. But like, I don't think I buy that. I think when you're trying to fix the healthcare system, there are signals, right? I believe deeply that the well-being of moms and families is a bellwether for the well-being of society as a whole. So if moms are unwell, society is unwell. And that's why like every injustice in our society shows up in the well-being of moms. So there's gender inequity, racial inequity, geographic inequity, whatever the case might be. And so we should be looking at the signals in maternal health that tell us that society and the systems that support our society are not working, if that makes sense. That's what I see in the Accreta event. Not to put too much on your shoulders. Like, look at what's happening with Accreta, how people are treated, and how you know, and I think this is evidence that our healthcare system as a whole needs to be reformed.
Absolutely. So to clarify a little bit, just meaning how cesarean overuse creates so many downstream effects within the medical healthcare system that just demand such a huge use of resources. I mean, you alluded at the beginning to all the different functions that we have involved in placenta accreta deliveries, being at the tertiary trauma centers. And it would just be incredible. Like one of my long-term goals in advocacy as well is take some of those resources, and we don't want to, as a society, be spending them there. Like we want to push this upstream and to get a better handle on being more proactive in maternal health and really looking at the scope of a woman's whole reproductive life to set that woman and our healthcare system up to be more successful and to not need those downstream effects, because we're able to make change in the beginning in the right direction.
I agree. What I would say to build on that idea also, though, is that we need to treat the enterprise of building our families as an investment and not a cost. And actually, if we did, everything would be different. So like financially, 25% of all hospitalizations in the United States are either a mom or a baby after a birth, 25%. Cumulatively, that's 0.6% of our entire $17 trillion GDP. What that means is if you were to take our whole economy and like throw it onto the table, you'd be able to see the cost of hospitalizing moms and babies with your naked eye. It's like seeing the Great Wall of China from space. Apparently that's not a real thing, but like, you know what I'm trying to say. It's not a thing. Like you can't actually, whatever. The point is like, you can see that cost. It's a big thing. And also for all that spending, we're not getting value out of it.
Yes.
Right. And so I wouldn't want people to think that the solution is only that we need to move money around, because actually the thing is we don't need to be skimping on childbirth. Like this is the one part of our humanity that we should be investing, and we should just do it wisely.
Absolutely. So eloquent. Thank you so much, Dr. Shah. And I'd like to invite Jory in as well. I know we've been getting a lot of great comments and chats and some questions. So Jory, go ahead and share with us what you've been seeing.
Yeah, absolutely. There's been a lot of connections going on in our comments within the community, which is always a great bonus of these Accreta Expert Series live streams, because folks can connect with one another of whatever their zip code or time zone. We did have a few questions actually submitted in advance, and a few were all connected to a similar topic about some of the other inputs during the care delivery process that may contribute to increased cesarean rates. I know you responded during your presentation to some of the assumptions that we make about reasons for them. So we did have a question about your thoughts. This is from C.E. Durfee, about your thoughts on the continued use of continuous electronic fetal monitoring in hospital births, although research shows that may not clearly improve maternal or neonatal morbidity and mortality, and whether you would share your perspective about the use of intermittent auscultation for healthy pregnant people. Apologies if my pronunciation was incorrect there.
No, you got it right. Sure. And this is just my perspective on this. So just to rewind the tapes for everyone who may or may not be familiar with this, there is something to this. So in the early 1970s, like what changed? Why did the C-section rate take off? It was the introduction of a technology, which is what we're talking about here, which is continuous fetal monitoring, or just fetal monitoring in general. Like we introduced this technology, and everyone with electricity is using it within 3 years. And it perfectly coincides with when the C-section rate starts skyrocketing. It also doesn't explain the entire thing, because the way that we used fetal monitoring in the 70s, 80s, 90s, 2000s, 2010s, and 2020s has been the same. So it triggered it, but it doesn't explain the whole thing. The second most common indication for a C-section is a fetal heart tracing. And that data is garbage. It's not total, well, that's a little strong. Like, it's useful when things are really bad, and it's kind of useful when things are really good, but most of the time it's just ambiguous, and it's the excuse for bias. So to the point of the question, yes, intermittent auscultation can be really helpful. Also, and here's where I feel more, this isn't controversial, it's just how I feel, but there's a deeper problem with that, which is that you would think that intermittently using heart monitoring would be easier than continuous. It's not. When you have continuous heart monitoring, you can just sit at the nursing station and watch a monitor. When it's intermittent, you've got to like go into the room over and over again. And actually, and this isn't like nurses being lazy. This is like nurses being understaffed. We have like a massive workforce shortage. And functionally, the labor and delivery unit is an ICU. What defines an ICU is not the presence of a ventilator, it's the ability to staff one nurse to one patient. That's the definition of an ICU. And what's really interesting to me is actually the cardiac ICU and the labor floor have all the same capabilities, right? Like the cardiac ICU can staff nurses one-to-one, so does the labor floor. The cardiac ICU can monitor heart rates, so does the labor floor. That's what we're talking about. The cardiac ICU can titrate medicine on a minute-to-minute basis. That's what we do. That's what oxytocin is. The only difference between the labor floor and the cardiac ICU is that our operating rooms are attached. So we have the most intense treatment area of the entire hospital for the healthiest people. And then you're like, well, why do we do too many C-sections? Well, there you go. And at the end of the day, to get to intermittent auscultation, and this is the point of the story, you have to pay more for nurses. You need more nurses, and that's the barrier.
I imagine then maybe your answer to this other question that we received in advance may be similar, but we also had some questions about whether procedures like inductions or epidurals are similarly overused or improperly used, and the impact that those decisions, which are part of that complicated kind of architecture that you've been talking about, also impact C-section rates.
Yeah, I mean, there's a real fascinating history on how labor management has changed over the last 100 years. But even in a shorter time frame, like most of the people who are listening, their grandparents were probably born at home. Think about that. Like 2 generations ago, we were born at home and we died at home. We've institutionalized both in the modern era, and we've messed both up in similar ways, right? Like a living will, the purpose of a living will is to make sure we're not over-treating people at the end in ways that cause suffering, because people have goals at the end other than simply living longer, turns out. Just like people have goals other than emerging unscathed during childbirth. But the equivalent of a living will is a birth plan. And birth plans don't have the same recognition or respect in the healthcare system that a living will does, but very, very similar. And yeah, so like epidurals and inductions, they may be contributing. They are overused. And then there's complexity too. It's not like, I mean, it turns out like an induction doesn't necessarily cause a C-section. What the induction does is it causes a longer amount of time that somebody has to be on the labor floor and a costlier amount of time. And the way to decrease the cost and get more reimbursement is to end it.
I see a great question here from Jamie. Dr. Shah, can you comment on the ARRIVE trial and any impacts on C-section rates?
Sure. And hi, Jamie, social media friend. I mean, the ARRIVE trial is so interesting because it's like, so the ARRIVE trial was this like big clinical trial that changed a lot of management in the country overnight. And the premise is that when you're at 39 weeks, you can choose to be induced. And we used to not recommend it for anybody who didn't have a medical indication, but now we're like, actually, like, go for it at 39 weeks. And the reason that we didn't recommend it in most cases beforehand is because we thought that the induction causes the C-section rate. And what Bill Grobman, who led that trial, explained to me, and actually really influenced my thinking for team birth and everything else, is that it's not the induction, the decision to do the induction, just like it's not the decision to do the C-section. It's not the induction that causes the C-section. It's bad labor management. It's impatience. And did the ARRIVE trial net increased C-section rates, especially in community settings, 100%. But that's not the same thing as saying that an induction causes a C-section. And I think that's important, actually, because some people do need to be induced, and some people may have good reason to want to be induced. But we shouldn't, write out their fate. We should support them in labor.
I'm going to put a question from Lauren on the screen. And I know that, these decisions are very personal, but if you have some perspective on how you might counsel a patient like Lauren who asks, can you talk to those of us who have had multiple C-sections and do want more babies, but are worried about Akrita?
Yeah, sure. I think everything about pregnancy is deeply personal, and interestingly, everyone else seems to have an opinion about what you should do during pregnancy. And I would say, unfortunately, like, people who are pregnant are just judged a lot. If you've had 3 C-sections and you're gearing up for the 4th, you may find that you encounter some judgment. Also, like, the purpose of the healthcare system is to center the people that we're trying to serve, and building a family is personal. It's like, so if you want 4 children, then you should, that goal is what matters. And then what follows from that is, how do we best take care of you in ways that are safe and give you the information that you need to make a decision? But it's your decision to make.
Absolutely. Thank you. I'm going to put another question on the screen from Megan. She asks, could you comment on the Kendon report, which was recently released in the UK, and how countries all over the world could reduce C-section rates more safely? She notes that it's important that hospitals not only attempt to reduce primary cesareans, but that they do so in a way that is safe and respectful.
Yeah, 100%. This is a report that I think has been maybe a flashpoint in a brewing discussion in the UK in particular, within the NHS, among various trusts, where there have been a couple of audits around safety, and a really fierce and I think sad at times debate between people who've been harmed or have had bad outcomes, which are not the same thing, and this movement towards normal birth. The word normal is actually very fraught. And you guys have done a good job of actually qualifying, like a lot of times when you talk about decreasing C-sections, people feel personally judged for their C-section. And like, the point of the story is, like, there's a hospital and they probably did a lot of things that were not safe in promoting normal birth without holding both truths. You can hurt people in 2 ways: by doing too little too late, and by doing too much too soon. And that we can't be dogmatic about either side of this. It is true on balance, and I think it's important to be clear that in most cases we are doing more C-sections than we should, and also have empathy for the fact that part of the reason why that seems to be the case is that the consequences of getting this wrong are life and death. So a lot to unpack there, but I guess just from a values and just a humanities standpoint, what saddens me about this report is a lot of people are just being blamed. Actually, no, this is what I want to say about this. This is really important. A bad system will beat a good person every time. Reports like this, they should be about inquiries into systems and processes, and they shouldn't be about castigating individual people who are on the front lines doing the best they can to care for people in labor.
Such an important point. One of the things that I find so interesting about the conversation of cesareans and placenta accreta is that I think placenta accreta really just illustrates the amazing power of a C-section in both aspects, and that a C-section is one of the main reasons that most of us got here. Yet many folks, including myself and my son, wouldn't be here if it weren't for access to a C-section. in complications like what we've developed. So such an important tool, and it's really about utilizing it correctly and effectively so that we can have the best outcomes for moms and babies and experiences as well.
Totally. Yep.
We've had several questions from folks who are just asking about kind of diagnostic tools, screening tools, and I suppose it might be helpful for you to share your perspective on that, given all of your research generally, and again, architecture of, how labor and delivery wards work and how obstetric screening works. So, for example, some questions around how birth workers might look for what tools they could look for, what risk factors they should pay attention to, and to lend effective signposting and support to their patients, and vice versa, I'm sure, for patients as well.
You both would know better than me, but if you're going to give me a chance to think about it a little bit, I know that NAF has been promoting centers of excellence, and I think that's a really good idea. I think, in the cases where we do the identification, we should be thinking about the appropriate sites of care and stuff, but the identification really matters. And so sometimes that happens during an anatomy scan or something early on in pregnancy. But I think that there's an opportunity for me and all of my colleagues to be much more aware of when people come in, we should know, if you have a previa and you've had 2 prior C-sections, your odds of having an Akrita are very high, like coin flip high. And we should be no matter what the ultrasound looks like it says, we should be repeating it. We should be very vigilant, right? We should, and I'm not sure everybody thinks like that. And then sometimes you encounter an Akrita unexpectedly. And I think we all need to be trained and aware of what to do in those cases. I think, and that's not just the surgeon, that's everybody.
Yeah, I'll chime in on this one too. I think that an important part is awareness of Akrita and helping the obstetrics community to understand as well. There are folks who've been practicing for 40, 50 years who may not realize, honestly, that placenta accreta, what they thought of as this super rare thing, isn't so rare anymore. And really making sure that folks are aware of the risk factors and that they are giving appropriate screening, and also that patients are getting access to appropriate prenatal care, including those screenings. And I'd like to invite folks who are more interested in these types of topics. We have a fantastic FAQ on our website, which goes through kind of a lot of the latest literature and distills it down to what's important to patients. And some of our previous Accreta Expert Series interviews as well, we go in depth in these sorts of topics. And at this point, we've got a few minutes left, so I just want to do kind of a last call if anybody's got any comments, any questions that we want to put up here. And I also want to just thank you so much, Dr. Shah. This has been incredible. I see we've got a good question here from Samantha. Good point.
Yeah, I thought this would be great. I didn't want to miss this question. Your thoughts about increasing access to midwife care via midwives, as well as doula support to prevent overuse of cesareans.
Let's do it, right? The conclusion of the Ockenden report shouldn't be that when you compare us to the places we want to be more like, and we do want to be more like the UK in many ways, midwives are at the center, and also people deserve support. And you wouldn't run a marathon without a coach, why? And I will tell you, a lot of partners, especially dudes, I'm just going to say it how it is. We're not good at this. I'm an OB and was not didn't totally know how to support my wife through the whole process. So I think that we have to be humble about expertise, and my expertise is to operate and to deal with medical complexity, but we've actually designed the system backwards, right? What everyone in labor deserves is access to support, coaching, monitoring. Some people benefit from the epidurals and the medical science, and actually relatively few benefit from what I do and was trained to do, but everyone gets me in the ICU. And actually very few people get the kind of support they deserve. So we have to do all that.
Absolutely. Well, thank you so much for being here today with us, Dr. Shah. This has been incredible. And everyone, we will have this recording up and available for folks who want to go through it again, share with others. And at this point, I'll go ahead and hand it off to Jory to close us out.
Yeah, thank you. I just want to echo Kristen's thanks. This was a real privilege and pleasure to hear from you and have you here with us in our community. So for all of you who joined us or are watching this on demand, if this is a cause that you care about, just want to remind you that we have many ways you can get or stay involved, whether in your own care or as an advocate or provider. So really encourage you to visit preventaccreta.org/CAM, C-A-M, to find tools, graphics, messaging, important facts, and other ways you can help spread the word and connect with our community of survivors. So if you haven't already, please consider sharing your story with us so that we can continue to highlight real examples of how upstream factors impact patients and families downstream. You can also share it from your social media accounts and tag us at Placenta Accreta. We hope you found this a welcoming, supportive, and informative platform, and we look forward to seeing you at our next Accreta Expert Series live stream.